Thank you very much and welcome to the session. I'm honored to be co-hosting this session of the International IVF Initiative. So for videos and previous sessions, please go to ivfmeetings.com and please write a review. It's very easy. You just have to click a button, and please, we've got over 150 videos there, so please write a review. I'd encourage you all this evening to ask your questions in the Q&A section of the conference service and not on the chat function. My name is Giles Palmer, and it's an honor to be co-moderating this session with Dr. Peter Nagy, and our panelist tonight is Professor Ellen Goossens. Dr. Nagy is one of the founding members of I3 and is the Scientific and Laboratory Director at Reproductive Biology Associates in Atlanta. He's been an invited speaker in hundreds of meetings in over 50 countries around the world, and is author and co-author to over 200 publications, including dozens of book chapters and 5 books. So please, for further information, go to the website and you can check out his further accomplishments. Also tonight, we have Professor Ellen Goossens, who's here to bring her expertise from the research group Biology of the Testes, or BITE as it's called, which studies spermatogenesis and a special focus on spermatogonial stem cells. The current aim is to develop strategies to prevent male infertility after spermatogonal stem cell loss. She's affiliated to the Faculty of Medicine and Pharmacy at the Free University of Brussels, the VUB, and full professor and exchange coordinator for students in biomedical sciences. She was awarded the prize of the Royal Belgian Academy for Medicine in 2011 for her work on prevention of infertility after chemo or radiotherapy. She's a basic science officer for the special interest group on andrology of the European Society of Human Reproduction and Embryology. And now, Peter, over to you.
Thank you so much, Giles. And it is a great pleasure and honor to moderate together with Giles this webinar, who is the executive director of the International IVF Initiative, and he is doing a fantastic job about that. And he has been a clinical embryologist for over 25 years. He has been both lab manager and clinical director, skilled in laboratory, business, and quality management. Please check out his full bio on the ivfmeeting.com website. And next, I would like to introduce Dr. Sherman Silber. He doesn't really need any introduction, but if we want to give him a proper introduction, it would take longer than the webinar itself. So my deepest apologies, Sherman. I will really just try to focus on some of the highlights of many of those that you have throughout your career. So Dr. Silber went to medical school at the University of Michigan and did a postgraduate training at Stanford University, then again back to the University of Michigan. He performed the world's first microsurgical vasectomy reversal, as well as the first testicle transplant in the 70s, and now in the current century, the world's first ovarian transplant. He was the first to develop the TESE and MESA techniques for retrieving testicular and epididymal sperm in azoospermic men. He headed the clinical MIT team that first mapped and sequenced the Y chromosome in infertile men and discovered the now famous DES gene for male fertility. His research includes also the study of reproduction and fertility in zoo animals and endangered species. Dr. Silber has treated many thousands of infertile couples who travel to St. Louis daily from all over the world. His patients come from every state in the US, all over Europe, South America, Middle East, Asia, and Africa. He is the author of 5 medical textbooks, also 5 best-selling books, and for the layman, and for more than 250 scientific papers on human infertility and reproduction. And it's my big pleasure now to give you the microphone, Sherman, to go ahead and talk about the surgically retrieved sperm. Thank you.
Well, thank you, Peter, very much. I remember dearly how we first started working with ICSI and sperm retrieval together in 1993 in Brussels. And actually, I have here the picture of the very first Tessa babies that were from Brussels in 1993. They were twins, and they were the result of testicular sperm extraction with Paul Devroy and myself, and we were obviously much, much younger then. I'd like to just go through the basics for a few minutes, and I will stick closely to time, so I'll go relatively quickly with this. Now, this is just a classic slide of normal spermatogenesis. The important thing to note is that you see the normal sperm are really what you see as oval appearing sperm heads, and you don't see the tails. And you don't see the tails on histology in most sections because the tail is so tiny and the sperm head is 4 by 6 microns. And so it is what shows up in a thin slide, but the tails usually don't. I've actually heard urologists call this maturation arrest because they didn't see tails. Now, you may not believe that, but I've heard it at many urology meetings. So this is just normal spermatogenesis. And what you see are elongated spermatids. But when you do tests on this kind of a case, they're not really elongated spermatids. I mean, they look just like sperm with a cytoplasmic droplet on them. So a few quick statements about spermatogenic stem cells. They stay in the basement membrane and they renew themselves very slowly. And this slow self-renewal is important for all stem cells to limit the number of mutations over time. They make progenitor spermatogonia, which multiply at the fastest rate, but can't self-renew. But they are what really leads to this huge number of differentiated spermatozoa. The spermatogenic stem cells are relatively strong and resistant to damage by chemotherapy. And so very often in cases like post-cancer, you will find eventual recovery of a small amount of spermatogenesis, sometimes completely normal spermatogenesis, because of the sturdiness of those spermatogenic stem cells that are very, very hard to see and specify on histology or even with markers. So the spermatogonia divide at different rates, and the dark type A are the ones that proliferate the slowest, and they contain the SSCs, and the pale type ones are the ones that divide so quickly, and they're the ones that are destroyed right away by chemotherapy. So SSCs can produce spermatogenesis and thus restore fertility if transplanted into the reedy testes. And there should be no cancers in the testes of a prepubertal boy with leukemia after his initial remission, but the more sturdy SSCs are likely to survive that initial chemotherapy. So what about the hormonal control of spermatogenesis? That's an important side issue also. FSH only will produce what we call a fertile unit. The testes make sperm, but not many sperm, and they're very poor quality. Add a little bit of LH, and you get completely normal spermatogenesis. In Kallmann syndrome, if you give only HCG, you'll get maturation arrest up to the pachytene stage, but you won't get sperm. You add FSH briefly, and then suddenly you have normal spermatogenesis, and then you don't have to give FSH anymore. All you really need is the LH or the HCG. So this is when you're giving HCG only to a Kallmann syndrome patient, and they've got maturation arrest, and that's true maturation arrest. There won't be any sperm there. But then add a little bit of FSH, and you have normal spermatogenesis. So that was just a sort of an introduction. You should know something, a urologist should know something minor like that, at least about spermatogenesis, so that they can know how to intelligently approach obstructive and non-obstructive azoospermia. So I believe that for obstructive azoospermia, patients prefer an anastomosis if the one is possible. But after a vasectomy, there's usually pressure buildup that causes secondary blockage in the epididymis. And so you wind up going to the epididymis rather than just reconnecting the vas in the majority of cases. And this is how we retrieve sperm, and we called this MESA when we first started doing this, first in California, then in Brussels, successfully with ICSI. Now, let's say there's a vas to reconnect to this blocked epididymis. Well, we would do a specific tubule vasoepididymostomy, and the results are remarkably good. These are just a few of the very pretty pictures that just show that we can do a perfect anastomosis of the vas to the opening in the epididymal tubule if there's a vas present to anastomose. And the success rate is only related to the age of the female partner. This is a simple problem, obstructive azoospermia. And you can see this is a curve similar to Vesey et al. In terms of the months to conception after discontinuation of any contraceptive. And we could impose these slides of months to conception after vasoepididymostomy, and they superimpose just perfectly based on age. But so what about if there's no vas to reconnect and that's not possible? Then what we have to do is sperm retrieval and ICSI. And the very first slide I showed you of Paul Braye and myself was a patient that had had no epididymis at all. And we figured, well, let's see what testicular sperm is like. And of course, testicular sperm looks terrible, but ICSI solves that problem. So here's how we now do microsurgical TESA and MESA. We do it under local anesthesia. There's no need for the patient to be asleep. You inject the cord with 10 cc's of the anesthetic, and then you inject the anterior scrotal skin. And the patient can watch the entire procedure on a television screen. Now, this is an old slide, really, from 1996. So you can see that for a long time we've been doing it. And we would never use a general anesthetic or resort to that for a microsurgical TESA procedure. And the patient just gets up when we're done and walks away. But now realize that the physiology of the epididymis is different under obstruction than normally. So normally that distal epididymis is where you have motile sperm, and the sperm coming out of the testes has no motility. The sperm in the head of the epididymis has no motility, and they gain their motility as they travel through the corpus epididymis. So the distal sperm are fertile and the proximal sperm are just not motile at all and not fertile, just like the testis sperm are not fertile. Now it's different in the face of obstruction. In the face of obstruction, these distal sperm are old. They've been made a long, long time ago and they're senescent, and they either have no motility or they have DNA sperm fragmentation. There you can see these are old slides, but this is the DNA sperm fragmentation. We didn't need COMET assays, or we didn't have to call it DNA sperm fragmentation. It was obvious that chromatin breakdown occurred in senescent sperm distally in the obstructed epididymis. But then if you go to the proximal most epididymis, that's where you find the good sperm, where you don't have chromatin breakdown, you don't have senescent changes. That's where you have the fertile sperm. Now, they're not really very fertile unless you use ICSI. And I'll show you in a minute the difference in our success rates between 1986 and 1993 before we really had ICSI. This was our paper in 1994, actually. And you can see that when we did IVF regularly with microsurgical epineal sperm aspiration, the fertilization rate was only 7%. Only 19% of patients had transfers, and the delivered baby rate was only 4.5%. And when we then did ICSI, first in Brussels, we published in 1994 with Peter that now suddenly we have a 47% fertilization rate, 94% of the patients had transfers, and pregnancy delivery rate was 36.3%. Of course, it's higher now because IVF has improved so much since 1994. But we also showed, and I believe we were the first to show that in 1997 with these obstructive azoospermia cases, that the pregnancy rate and the implantation rate is strictly related to the age of the wife. There is no correlation to where the sperm came from. The correlation of success rate is strictly related to the age of the wife, even though it's male factor infertility. Now, non-obstructive azoospermia is a trickier issue. And I have to say, Paul Braye first thought of this. He read a paper that I had written in 1979, actually, in which I was trying to compare mature spermatid counts on histology of the testes to what the sperm count actually was, to see if we could predict the sperm count from the testis biopsy. And that was the original paper in 1977, actually. And I did not conceive at that time, I thought it was just an academic, maybe dull paper, and I did not understand the extreme importance of it until ICSI came along and Paul Braye read this paper and said, I really think we have something here. What Paul noticed is that on this graph, you had to exceed a certain tiny number of spermatids per tubule in order to have any sperm spill over into the ejaculate. So azoospermic patients often did have some mature spermatids in the testes, and they were not failing to make sperm completely. So this is an example that's very picturesque you can look at of non-obstructive azoospermia, where you see Sertoli cell only in the upper left hand and a tubule with normal spermatogenesis in the lower right hand. So you can have a sea of Sertoli only. You can have a diagnosis on routine biopsy of just Sertoli cell only, but that doesn't mean there won't be a few tubules with normal spermatogenesis. And we found in 60% of the cases there were. Now, I'd like to emphasize our approach because there's a popularity of approach called microdissection that all the urologists are being taught how to do this, and it's really, really very dangerous, and it's really stupid. And the urologists are doing it because they don't really understand the physiology of the testes. You want to sample every anatomic lobule peripherally, but you don't want to dissect inside the testes. I can show you what damage that causes. So here's Sertoli cell only, obviously. And you can see the Sertoli cell nucleus has a prominent nucleolus. And so in the early years, people were injecting these Sertoli cell nuclei thinking they were round spermatids, thinking that our goal was just to get immature sperm, and that is not what we're doing. They were actually trying to do somatic cell nuclear transfer without realizing it. And of course, you can get cleavage, and there were even some claims of pregnancies, which I'm sure were fraudulent. And I don't say that lightly, but I say that very, very strongly and decisively. They were just fraudulent claims. And so that's where you can get confused, and I'll show you in a minute. This is maturation arrest, but only partial, because if you look at the 1130 position, you can see a few elongated spermatids. So in Sertoli cell only, in 60% of the cases, you can find an occasional tubule with sperm, and in maturation arrest, the same thing. You see only pachytene spermatocytes, except you can find an occasional area where there actually is development to mature sperm, and you can have success with that too. This is routine TESA lab dissection. We really prefer that to using enzymes now. We've tried them both. And you look through there and you see red blood cells there, and you see Sertoli cells with Sertoli cell nuclei, and you actually see a sperm, a rare sperm, and you just pick the sperm up. And the success rate we found is the same as with ejaculated sperm. Now, I just make a point, do no harm. I'll give you just one example of a patient, but there's many patients like this. Eagle Majar, who's actually accumulated these cases in Israel that originally had microdissection in the US, has a huge series of these. 37-year-old physician with a 33-year-old wife. He moved to St. Louis from New York and gave me this history. He had a preoperative testosterone level of 371, and he was normal, but he was azoospermic. So 15 months earlier, when he was living in New York, he underwent a microdissection TESA procedure. No sperm was found, but since then he noted increasing fatigue, muscle weakness since surgery, and his testosterone, when I saw him, was now 15 months later, 84, with an LH of 50.5 and an FSH of 75.3. He essentially was castrated by his microdissection procedure. So he wanted us to operate anyway, and most of these patients want us to check anyway to see if there's any normal tubule there at all with sperm. And this is what you see when you microsurgically look at this. It's just areas of dense fibrosis where microdissection has resulted in disruption of the very delicate blood supply of these end arteries. Now, also, the silly thing is you really can't tell where the sperm is by looking at the tubule size. Originally, I hoped that would be true, but look at wherever the tubule makes a turn, it looks fat, but that doesn't mean there's any spermatogenesis in that tubule. So just take a look at this. Here you see Sertoli cell only tubule on the lower left, next to normal spermatogenesis tubules on the upper right and on the right. And they're just as thick as each other. You cannot tell by that thickness under an operating microscope where the spermatogenesis is. So I recommend for everyone here the spermatogonial stem cell approach to TESA. So it's safe and it really works. And I got this idea originally from David Page, who I worked with for so many years on the sequencing of the Y chromosome and the DAS gene and finding the genes that are associated with azoospermia. So you sample every anatomic lobule peripherally. And if there are any spermatogenic stem cells anywhere within the interior of that testis, there will be sperm on that outer loop. And this is an example for a complete maturation arrest. We really do see the tubules are thick. You wouldn't know where to go, but every anatomic lobule is going to be sampled, just the peripheral 1 millimeter of it, and we're not going to interfere with the blood supply. Now, we do it microsurgically. We'll cauterize all the bleeders very carefully so that when we close it, we won't have any hematoma inside that would cause pressure necrosis, because the tunica albuginea has no elasticity whatsoever. So this is Sertoli cell only. You can't tell where the sperm are here. You just got to sample every anatomic lobule peripherally. And then you close it microsurgically, not grossly, with continuous sutures that would purse string and compromise the intratesticular space and cause pressure atrophy. You close it microsurgically, like ophthalmologists routinely do their corneal transplants. And so that testis has undergone no harm whatsoever. We haven't damaged into arteries. We haven't created any internal obstruction of the seminiferous tubules because they loop around peripherally. And you can see my thumb in the lower left hand. It's not a big testicle, but this testicle, if we had to, we could go into it over and over and over again and retrieve sperm and result in no damage. Now, let's talk for a second briefly about the round spermatid controversy, because that really created an incredible stir from our first reports of this in 1994 to almost the year 2000. Now, this is an electron microscopic view showing you that the round spermatids, before they develop a tail, have this acrosomal vesicle that is very bright. And actually, Bob Edwards used to smile and say, the round spermatids glow. If you look at them under phase contrast, they glow. And it caused von Sturtigum and DeVroy and me really to laugh, but it's really true. You can't miss them, at least with phase contrast. But when they disappear when the tail begins to form. So you will not see round spermatids in the absence of what looks like a sperm with a tail. And here's another transmission microscope where you can see this big acrosomal vesicle, and it's about to change and wrap around the sperm head as the tail is forming. But now look on phase contrast. These arrows are pointing to Sertoli cell nuclei with a prominent nucleolus. And this is what was being injected. There are many publications on this as round spermatids, with the mistaken idea that what we're trying to do with TESA for NOA is to just inject immature round spermatids because there are no mature spermatids. That's stupid. That does not happen in the human. In the human being, you never see round spermatids in the absence of elongated spermatids with tail. So here's a good example of that. You can see under phase contrast that Bob Edwards is right, the round spermatids glow. But if there's going to be a round spermatid in that specimen of TESA, you're also going to see sperm, which you can also see with tails. So there's no predictive test parameters for finding sperm. In the normal testes, there might be hundreds of millions of sperm at any time. But in non-obstructive azoospermia, we're looking for 10 to 20, maybe 1 to 5 sperm. So there's a million-fold decline in sperm, and that will still permit successful TESA, but we're not going to see this with FSH or most other tests. Now, I will modify this for a second. And before I get to Klinefelters, because I think I have about 5 more minutes left, a recent study by Brian Herman. I'm one of the authors on it. I was a stupid author. All I did is provide them with specimens of normal spermatogenesis from men undergoing vasectomy reversal who had normal spermatogenesis. And he did a massive study. It was a 5-year study of doing a single cell transcriptome analysis firstly, to find the markers that were available, that actually would exist in the human for spermatogonial stem cells, but also to characterize completely the expression of genes throughout the whole range of spermatogenesis. And one of the side products of that is, if that were readily available, Brian Herman can tell you on a biopsy, just because it's so really predictive, whether or not there are any mature spermatids. Now, this is a case of Klinefelters, just to show you how different it is from Sertoli cell only or maturation arrest. You see all that yellow? That yellow is typical. Those are Leydig cells. And this is a Klinefelter's patient who has normal testosterone. You can see Leydig cell hypertrophy, but you barely see a tubule. And we close it carefully. We don't want to do damage to these tiny testicles, and we don't. And then you look at some places and all you see are just corpora albicans and fibrotic tubules. But then you'll find somewhere in 60% of the, more than 60% of these Klinefelter patients, a tubule with normal spermatogenesis. And those are XY areas, because what happens with Klinefelters is they're mosaics. And if they're mosaic in the testicle, there's got to be some tiny area where you have normal spermatogenesis. And so this is the first Klinefelters we get, healthy twins, normal embryos, and other Klinefelters. And I might want to add, Klinefelter's patients are not mentally retarded or mentally deficient. They can be reproductive endocrinologists, as a matter of fact, or embryologists. It was really a problem that with the severe cases had no testosterone production as teenagers. And so they had that slow problem and they weren't replaced with hormones. But the vast majority of Klinefelters really are just like you and me, and they're just totally normal, except that they're either making no sperm or very few sperm. So this is another one. You see the yellowing of the Leydig cell hypertrophy, and you see some Sertoli cell tubules, but also tubules with normal spermatogenesis. And you close it carefully. You close it microsurgically. You don't microdissect this testis and destroy its testosterone production. Healthy twins again. Now, we also see a lot of men with Turner's mosaic. They're XYXO, and they're short, and they have the same testicular appearance as Klinefelters. And most of them, you'll find sperm. This is a perfect example. Looks just like a Klinefelter's with a yellow Leydig cell hypertrophy, and you see Sertoli cell only, and then you see a tubule with normal spermatogenesis. You close it properly, normal kids. So what about the results? Well, I would maintain from all of our observations that the varying degree of male infertility and numerical number of sperm is just not related to the success rate. It's only related to female factors. This is a big, busy chart, but whether we were looking at azoospermia or less than 2 million or 2 to 5 million or 6 to 20 million or greater than 20 million or donor sperm, at that time, the success rate was strictly related to the age of the wife and not to the sperm number. So what is the future of TESA? Well, you can actually retrieve testis tissue from prepubertal male cancer patients, or retrieve the tissue after initial rounds of chemo, preserving the SSCs but killing the cancer cells, and then transfer those stem cells back. And this is just, we're practicing, so we'll be ready to do this. This is just a volunteer who is undergoing vasectomy reversal, and we did no harm to him, but you can see with ultrasound guidance, and we've done many of these, that it's very easy to transfer anything through the reedy testes in the human. Just keep watching and you'll see the seminiferous tubules just filling up, and you can colonize all the seminiferous tubules with spermatogonial stem cells if you just inject the reedy testes under ultrasound guidance. And we found no damage from this procedure. It just is a way of much easier than in the mouse of transferring spermatogenic stem cells into seminiferous tubules. So my time is up now, and I finished my talk, and I just want to conclude that I've made a lot of controversial statements intentionally so that you can ask questions and try to grill me on them. We've had a lot of experience, Peter and me, since 1993 on this. Thank you very much.
Well, thank you very much. That had so much in there. That was a masterclass, and time did fly by, but you kept exactly the time. So we've got lots of time for Q&A later. there's so many questions about Rosny, there's about round cells here, but I'll pick one which is a question which is many times asked is there any evidence that spermatozoa in the testes has less DNA fragmentation than ejaculated spermatozoa? So should we be going into the testes more frequently, perhaps if a man does have high DNA fragmentation?
Well, you know, they're absolutely right in terms of basic science. The testes has mostly recently made sperm, and so you don't see that senescent change of DNA fragmentation in the testes that you can see in the ejaculate. No question, that's true. But from a clinical point of view, I'd be very conservative about just operating on a man's testes if we can get sperm that don't have fragmentation in the ejaculate, because the ejaculate is going to have a combination of all kinds of sperm with terrible motility or zero motility or abnormal morphology or fragmentation or no fragmentation. So I'm conservative about the idea of routinely going to the testes, because I think we can do just as well with ICSI, with ejaculated sperm.
Right, and that goes back to one of your slides, which was you know, do no harm as well, of course.
Right, right.
Okay, well, thanks. Well, there's so many questions. We'll certainly have a lot to talk about in the Q&A, but it's now my pleasure to introduce Aude Braye, who studied biomedical science at the Free University of Brussels. For her master's thesis, she studied the long-term culture of human testicular cells at the research group, the Biology of the Testes, or BITE. After graduation, she worked for 2 more years as a medical lab technician at the Center for Reproductive Medicine at the Universitair Ziekenhuis in Brussels, before returning and rejoining the very same research team, BITE, as a PhD student investigating how the testicular tissue biopsy procedure performed at a young age for fertility preservation may affect the pubertal development and fertility, in fact, of cancer patients and of Klinefelter syndrome patients. So it's my great pleasure to leave the floor to you. Thank you very much.
I will give a short overview about the fertility preservation in boys, the recent developments and the new insights. So, as I said before, I will give a short introduction about fertility preservation, and after that, I will go deeper into the management of fertility preservation. So what is fertility preservation? It's an emerging field that includes a variety of techniques or strategies protecting the future reproductive ability of individuals with cancer or other serious illnesses. Male fertility preservation is needed because cytotoxic treatments induce germ cell loss. So a little background, so the male gonads, they contain spermatogoneal stem cells. They are present in the testes since birth, and they are at the foundation of the spermatogenesis, so the production of mature spermatozoa. The spermatogenesis starts at puberty and continues throughout adulthood. So if there is loss of the spermatogoneal stem cells, it will lead to fertility problems. It can go from subfertility to infertility depending on the treatment intensity. So what are the methods and the best time point for male fertility preservation? The best time point is before losing the spermatogoneal stem cells, so before initiation of the gonadotoxic treatment. For the method, it depends on the pubertal stage of the patient. The adults, they have ongoing spermatogenesis, so they produce spermatozoa. These can be collected by masturbation and afterwards cryopreserved. The prepubertal boys, they have no ongoing spermatogenesis, so they don't produce spermatozoa. Their only option is the collection of the spermatogoneal stem cells by taking a testicular biopsy, following by cryopreservation of this biopsy. For pubertal adolescents, there are 2 options. If the adolescent is able to provide a semen sample, this semen sample can be cryopreserved. If the adolescent is not able to produce a semen sample or has not entered puberty yet, the only option is to cryopreserve the testicular tissue. So fertility preservation is in fact one step in a multi-collaborative care pathway, including physicians, nurses, and also psychologists involved in both oncology and reproductive medicine. Very important for this multi-collaborative care pathway are well-informed care providers, a very good communication between the oncologist and the reproductive specialist, and also a good dialogue with the patient and his parents. This will facilitate the decision towards fertility preservation. It will also increase the patient referrals and increase the acceptance rate for fertility preservation. Of course, the oncological therapies have priority over fertility preservation, but fertility preservation should be discussed and considered if possible. A little bit more about the procedure of banking immature testicular tissue. So the surgical removal of testicular tissue is an invasive procedure. After the procedure, the biopsy is cryopreserved, and today there is no standardized protocol available for the freezing of human testicular tissue. Most centers use a slow freezing protocol, in which the testicular tissue is cut into small fragments that are then transferred to cryotubes containing cryoprotective medium. These cryotubes are then transferred to an isopropyl alcohol freezing container until they reach -80 degrees. And after that, they are transferred to nitrogen gas for long-term storage. Some studies also evaluated vitrification or ultra-rapid freezing, but vitrification was not proven to be better in relation to tissue and cell integrity. Last year, we performed a survey in 24 sites around the world, offering testicular tissue banking to prepubertal boys. Here on the table, you can see the results of this survey. And what we see is that there is an increase in the acceptability for fertility preservation in prepubertal boys. You also see that there is no minimum age for fertility preservation, and that most boys were diagnosed with malignant diseases, but also boys with non-malignant diseases and genetic abnormalities cryopreserved their testicular tissue. Here you can see that all of the centers use the slow freezing protocol, and very important is that in 50% of the coordinating centers, the healthcare partially bears the cost for testicular tissue collection and storage. So what is follow-up after testicular tissue banking and why is it necessary? So it's the follow-up after banking is necessary in order to validate and adapt the patient selection criteria. This is necessary to prevent unnecessary surgery in patients who will retain the natural fertility after treatment, but also necessary to offer banking to the patient who will face fertility problems later in life. We have short-term surgical complications, but we also have long-term complications on the reproductive function as well as the fertility. So a little bit more about short-term complications. So the removal of testicular tissue is considered a relatively low-risk procedure. It's in most cases combined with other procedures necessary to minimize anesthetics. The overall complication rate is very low, between the 2 and the 3%. Most of these complications are typical surgical complications like infection, bleeding, or hematomas. Also, a few days after the biopsy, the testes can be sensitive, the scrotum can be discolored or swollen, and most of these complications disappear within a few days. But standardized guidelines for pre, peri, and post-operative management are necessary. So what are the recommendations for this follow-up? First is a regular assessment of the reproductive function. That is done by assessing the pubertal staging using Tanner stages, by assessing testicular volume, and also the gonadotrophin levels, the Sertoli cell function, and the testosterone level. We can also assess fertility in adulthood, and that's done by measuring the testicular volume, the gonadotrophins and testosterone levels, and also by performing a semen analysis. Currently, there are some data available on medium and long-term follow-up after testicular tissue banking. Here you can see some studies who focused on the gonadal function as well as reproductive health following pediatric gonadotoxic treatment in combination with testicular tissue banking. The first study demonstrated that there was no difference in testicular growth between the biopsied and the non-biopsied testes. The second two papers showed that there was subnormal testicular size, also abnormal gonadotrophin levels, and severely impaired semen parameters. They concluded that it was resulting from the treatment and not from the biopsy procedure itself. So now a little bit more about the future options to restore the fertility. So using the cryopreserved testicular tissue in order to restore fertility in males is still under development. The research is now focused on three approaches. The first one is the propagation of spermatogoneal stem cells in combination with transplantation. The second technique is the grafting of testicular tissue, and the third approach is the in vitro spermatogenesis. Very important here to mention is that for both first techniques, there is a risk to reintroduce cancerous cells that infiltrated the testis before the biopsy was taken. This can be the case in non-solid tumors. And today, there are no clinical methods available to exclude potential cancer contamination in the testicular cells or testicular tissue. Now we'll focus on the first approach, that is the propagation of spermatogoneal stem cells in combination with transplantation. So the first step would be the propagation of spermatogoneal stem cells in vitro. This is necessary because of the very small numbers of spermatogoneal stem cells present in the prepubertal biopsied testis. It has been demonstrated using human spermatogoneal stem cells from adult as well as prepubertal testicular tissue. But not only the spermatogoneal stem cells will propagate in vitro, also the somatic cells will propagate, which will lead to somatic cell overgrowth and, as a consequence, a very low percentage of spermatogoneal stem cells in culture. So further optimization of this technique is necessary, and this can be done by identifying specific SSC markers or a combination of markers for the spermatogoneal stem cells. The second step is the autotransplantation of these spermatogoneal stem cells into the seminiferous tubules via the rated testis. It has been performed in non-human primates, where it has been proven that the spermatogoneal stem cells could recolonize the testis after transplantation. And also successful embryo development was demonstrated after transplantation. This has been optimized using isolated human cadaveric testes. But there also here, the genetic and epigenetic stability of the spermatogoneal stem cells during the culture and after the differentiation is very important, and a limited number of research has been performed. One study demonstrated no tumor growth after transplantation of human spermatogoneal stem cells in mice. The second approach was the grafting of testicular tissue. One of its benefits is it maintains the spermatogoneal stem cells within their unexposed natural niche. So it preserves the interaction between the germ cells and their supporting somatic cells, which is very important. We can transplant back at 3 locations. We can do it ectopically, in the scrotum, or into the testis. By ectopic grafting, so for example in the ear or under the back skin, when marmoset of human testicular tissue was transplanted in mice, no full spermatogenesis was obtained. One of the reasons could be the higher temperature in these ectopic locations compared to the temperature in the scrotum. That could lead to sclerosis of the graft or meiotic arrest. Second location is transplanting into the scrotum. And by transplanting immature human testicular tissue, they were able to prove that the spermatogoneal stem cells could proliferate, and also they obtained spermatids. And then we have intratesticular grafting, so grafting Anotunica albuginea. When grafting non-human primate immature tissue into mice, they obtained secondary spermatocytes. Also, meiotic activity was proven when human testicular tissue was transplanted in mice. But there was a considerable loss of the spermatogoneal stem cells due to tubal degeneration in the center of the graft after hypoxia. The treatment with VEGF could improve the revascularization as well as the survival of the spermatogonia. The autologous transplantation was also performed in non-human primates. After ectopic grafting under the skin, they observed meiotic arrest. After grafting into the scrotum, they had full spermatogenesis, but a very poor spermatogenic efficiency. And then in 2019, by grafting larger fragments under the skin or into the scrotum, a healthy non-human primate baby was born after ICSI. So the third approach is the in vitro differentiation of spermatogonial stem cells. Very important for this approach is the survival and the differentiation of spermatogonial stem cells. And this depends on 2 points. The first one is a direct contact between the germ cells and the functional somatic cells. And the second one is a functional macroenvironment that resembles a 3D organization of the seminiferous epithelium in situ. Therefore, 3D conditions have been developed, like organotopic culture or testicular organoids. Using human tissue, in this study, prepubertal human tissue, there was spermatogonial survival, and also the seminiferous tubules contain their architecture. Using adult human tissue, spermatids were obtained, and using prepubertal human testicular tissue, we had meiotic and post-meiotic cells. And one study also used frozen prepubertal human testicular tissue and had haploid cells. But very important here is that the in vitro production of spermatozoa starting from human prepubertal testicular tissue is still not available in human. One of the reasons mentioned by this article is the incomplete establishment of the blood-testis barrier. So here are a few take-home messages from this presentation and also the next challenges. The first take-home message is that we have an increased acceptability for fertility preservation in prepubertal boys who are at risk of losing the spermatogonial stem cells. A first survey in 2012 had more than 250, approximately 250 boys who cryopreserved their testicular tissue, and our survey in 2020 showed more than 1,000 patients. Very important scientific progress has been made concerning the fertility restoration methods. Namely, the spermatogonial stem cell transplantation was translated to human cadaver testis. There was proof of concept for testicular tissue grafting into non-human primates. Very important steps for in vitro spermatogenesis have been made, but there is still a need for successful clinical trials demonstrating the safety and efficiency of fertility restorations. And until that, the testicular tissue banking for fertility preservation remains experimental. So here you can see in the table a few clinical as well as research challenges for the next years. So this was an overview of fertility preservation worldwide, but we at the research group Biology of the Testis have as aim finding new solutions to overcome the male infertility. And therefore we have three great research topics. The first one is the infertility after gonadotoxic treatment, where we follow up boys who received gonadotoxic treatment during childhood and who choose testicular tissue banking. We also perform research about Klinefelter-related infertility, where my colleagues look for biomarkers for infertility or fertility. They also investigate the cause of infertility and the testicular fibrosis in Klinefelter patients. And the third topic is the in vitro spermatogenesis, starting from spermatogonial stem cells. So if you want more information about our research, you can find everything on our website. So with this last slide, I want to thank everyone from the Biology of the Testis research group and also every colleague of the hospital here in Brussels. And thank you for your attention.
Aude, thank you so much for this very exciting presentation. It was great to listen to it. Just a quick question before we start the general discussion. Do you have an idea that, in your center or around the worldwide, how many patients has received back either the spermatogonial stem cells as a transplant or how many got back tissue transplants?
Yeah, very good question. So until today, none of the boys who cryopreserved their tissue have been transplanted back. So no spermatogonial stem cell transplantation, also no grafting of testicular tissue.
Right.
Also
okay.
Worldwide, I don't think it's performed yet.
Okay, but this is just the option. Then theoretically, what you can do with it.
Theoretically, the options that can be used, yeah.
Excellent. Well, thank you so much.
Thank you very much. And it's time for the Q&A. And I'd like to ask someone who's been very patiently waiting, Professor Ellen Goossens, if you'd like to start us off, and perhaps from the many questions we have on our document, would you like to choose a question?
Okay. First, I want to say thank you to both speakers, because these were two excellent talks, and I'm happy to be part of this excellent webinar. There are many questions for Dr. Silber. I will take one. Is there any clear evidence that male fertility is declining, other than varying spermatozoa concentration?
Well, it's always a controversial subject, and it keeps coming up. But I don't think there's any good evidence that spermatogenesis is declining related to hormonal toxins or any of the various theories. But if you look from ethnic group to ethnic group or country to country, there will be differences in quantitative spermatogenesis. And this is more or less related to genetic differences. For example, in Japan, 30% of patients have Y deletions that are only polymorphisms, but are probably contributing to a lower average sperm count. And so different ethnic groups have separated off, and they may have differences in sperm and total spermatogonial stem cells and counts. That's possible. But in terms of over time, it's obviously very hard to get valid studies. I know there have been a lot of claims about it, and we've looked at all of those studies, and I really don't think the evidence is strong for the disappearing male fertility that we thought might occur. If it would occur, we speculated it would occur from the shortening of the Y chromosome and the mutations that occur from the Y not undergoing meiosis, at least the non-recombining part with its X counterpart, and that you would have a shortening Y chromosome and a decrease of spermatogenesis, and we called it the disappearing Y. But if that were true, it would have been occurring over millions and millions of years, not just over a short time span. So, and it's a long answer, but I don't really think it's valid that we're witnessing a decline in sperm count.
Sherman, may I just follow up on the same question a little bit, because I know that you have a fantastic knowledge and insight also of the different animal species, and just wondering, for instance, like chimpanzee, gorilla, etc. Is there any relevance to human? Is there anything that we can learn from looking at those different species?
Well, I think we can, and it's something you got to be careful about talking about, because you'll be accused of being a racist. So I've been quiet about it. But I gave a talk in 1999, actually, in Sydney at the World IVF Congress, in which I compared chimpanzees to gorillas because of their mating pattern, and then applied that to humans and the autopsy studies that were done in Hong Kong of Caucasians living in Hong Kong versus Chinese, and Roger Short's studies, really. And certainly sperm competition is going to lead to offspring with higher sperm counts. So in a promiscuous society like chimpanzees, where whenever a female goes into heat, every female in this troop of 40 is going to mount her, and obviously the most likely father will be, she'll have all that sperm in her, and the most likely father will be the one who had the highest sperm count. So chimpanzees have gigantic testicles. Gorillas, which are 4 times bigger than chimpanzees, have little tiny testicles. And Roger Short's theory, which I think is true, is that their mating pattern is that any gorilla is going, any silverback's going to have 2 or 3 female partners, and that's it. And if they're ever going to get pregnant, it's only going to be with his sperm. So because of their lack of sperm competition, they have tiny testicles. And so whenever there's a promiscuous society, you're more likely to have a higher sperm count than in a society that is not promiscuous. And by promiscuous, I'm talking the burdens on the female, really. But you could, when I presented this along with the Y chromosome and the theory of the disappearing male in 1999 in Sydney, the next morning, the Sydney Morning Herald had a headline. I was in the headline that says, American doctor says that if men want to stay around, they've got to play around. Yeah, I mean, to me, it's fascinating. The mating pattern and the promiscuity of a society will determine what the sperm count is, and that work was all done by Roger Short.
Right, excellent.
Of course, if you also think about the evolution, the millions of years to get this cell to be motile, and then of course you're having a biopsy and taking out this immotile form as well. Where are we with Sertoli cell only syndrome, and also of course for injecting just round spermatids? Is it the case that if you're patient enough, you will find mature sperm?
Well, there is one study from Japan from a few years ago in which they say they found round spermatids and they have babies from the round spermatids. It's a pretty solid group. But we started looking at every single sperm specimen, every tested specimen, we could find carefully again and again. And I will repeat that we never found a case where there was round spermatids, but no elongated spermatids with a tail. So I don't know, the search for round spermatids, I just don't think that's a valid approach. Now, it's very tricky to identify a round spermatid with ordinary Hoffman optics. I mean, you really would need something like phase contrast, and that's a little harder to use for ICSI, actually. So I personally don't see any future in it. And there's just that one study by one group that alleged that. And if you look at the pictures, you will see how it's really, really difficult to say that what they injected was really a round spermatid. So I'm really very, very doubtful about that. I think the secret of TESA for non-obstructive azoospermia is that in up to 60% of cases, you have to exceed a certain threshold quantitatively of spermatogenesis for anything to spill over into the ejaculate after it goes through the seminiferous tubules and the reedy testes and the 20 feet of epididymis and then the ejaculatory duct. And I mean, you have a sperm loss. And so a man will be azoospermic and still could have a very small amount of spermatogenesis. And that's what you're looking at by going into the testes. And we discovered that without realizing it. It's there in the data in 1977, but we had no idea what the significance of that was until Paul Braye pointed it out.
Perfect. Just a quick questions to Aude. Is there a minimum age for patients, to undergo, biopsy procedure or any other criteria when you would consider this option or not to consider?
So as in one of the results, there was a question asked in the survey, what is the minimum age and the maximum age of the boys who preserved in your center? And we didn't see any minimum age because I think the youngest boy was about 3 months, I think. So there is not really a minimum age for cryopreservation. Okay.
And the amount of tissue that you remove, I mean, any boy prepubertal age, relatively they have small testicle sizes. So how do you determine the amount of tissue that you remove?
Yeah, of course, very young patients we will remove more percentage of the testicular tissue comparing to older patients, but at our center we aim to take about 10% of the tissue, testicular tissue.
How many percent?
10% maximum. 10.
Sorry, couldn't catch it. 10%, you say?
Yeah, 10%. Yeah.
10%. Okay.
But other centers prefer to take less than 5%. There is no standardized protocol for it. It's a bit center dependent.
Right. Right. Excellent. Sherman, another question to you, if I may. Do you see difference in outcomes when frozen testicular sperm use versus fresh, and when frozen epididymal sperm use versus fresh? Any advice on that? I'm just trying to put it into perspective because, doing testicular tissue extraction is quite an invasive procedure. So the patient would prefer not to undergo again if there is some extra sperm left after the procedure, and you can freeze it. But is that frozen sperm could be as successful as the fresh one?
Well, I think so. It depends on how you do it. Now, we know that freezing sperm is going to kill half the sperm anyway. We've known that for many, many, many decades. And that's going to be true of testicular sperm also. So we would always freeze the sample if we found any sperm on fresh tessa. And then we will thaw it, but then we'll use pentoxyphylline. And we're only using pentoxyphylline as a way of identifying which sperm have not been killed by the freezing. Now, for a fresh specimen, you don't need to do that. I don't care if the sperm are motile or not motile in the testes. It doesn't make any difference whatsoever. Just inject a sperm that has a flexible tail and looks normal, and it'll be fine. You don't need to find a motile sperm because sperm aren't supposed to be motile in the testes. A few of them are, but they're not supposed to be. But we use pentoxyphylline on the frozen sample so that we can just identify which sperm we've killed by the freezing and just pick up only the motile ones. For epididymis, I forgot to make one careful warning maybe, is if you pick up distal testicular epididymal sperm, there will be more senescence and the results won't be so good. You want to get proximal for MESA. If you're going to use epididymal sperm, you want proximal epididymal sperm. But then there's no difference between fresh and frozen, and you don't need pentoxyphylline because those epididymal sperm will be motile. So you'll know right away which ones are viable and which ones aren't.
Perfect. Thank you.
Okay, Ellen, have you got a question perhaps to ask Aude?
Yes, indeed. I think it's a very interesting question. How long have you been followed up the patients that have banked testicular tissue, and have some of these boys already restored spermatogenesis?
Yeah, that's a very good question. So at our center, we started banking in 2002, so very long time ago. Other centers also started after us, and one of these centers, we recently reported their results on spermatogenesis after testicular tissue banking. There is a big question because in their center, they cryopreserve testicular tissue of boys with mild gonadotoxic treatments and very high-risk gonadotoxic treatments. And that's a big difference because in the patients we had a mild or low risk of toxicity, there have still spermatogenesis at adulthood. But in patients with very high-risk gonadotoxic treatments like alkylating agents, for example, there is very impaired spermatogenesis going to azoospermia. So it depends.
Can I have a follow-up question on that? So, sometimes in IVF in our center, and I assume others have similar experience, when we have a patient, a male patient who went through a cancer treatment, a gonadotoxic treatment, but still has sperm in the ejaculate, we see a much lower outcome after IVF, like lower fertilization, poorer embryo quality, not so good embryo development. So despite that the patient still has sperm, it seems like there is an effect somehow on the quality of the sperm, and that also shows in the outcomes of in vitro fertilization. What are your thoughts? What do you think is the explanation for that?
Maybe I take that question, Aude.
Yeah.
Well, indeed, the genetic material of the germ cells can be damaged as well by the gonadotoxic treatments. And therefore, at least in our center, I don't know about other centers, we advise patients who have had gonadotoxic treatments to use anticonceptives for 6 months or so before trying to get pregnant again because of these problems that may arise during pregnancy.
Can I follow up on that? Because this is something we're wondering about. And you would know that I really don't know the data on this, but men who have recovery of spermatogenesis and have fathered children, there are many papers showing that there's anywhere up to 35% or 50% recovery of spermatogenesis and actually spontaneous pregnancy. But do we have any data on the health of the offspring from these men who had recovery of spermatogenesis?
Yep.
That I would not know. I have no idea about that.
And what about, as a follow-up or a follow-up really, but what about the effect on the testicular volume and the testosterone output and even the bone density? I mean, is it too soon to tell, taking the sample?
Aude, maybe that's the question you can answer.
Yeah, so we perform follow-up of these boys. We follow them for a few years, about approximately 5 years, and we have a limited number of data because there was no standardized protocol in which was described what we had to follow up. And currently we have data on bone age, for example, and there was taking a biopsy had no effect on their bone age. So their bone age can be delayed or accelerated because of the treatment, but the biopsy procedure had no impact on the bone age.
And it was in fact the same for the testicular volume. So the treatment on itself does have an effect on the testicular size, but taking a biopsy does not increase that harm.
Interesting. Sherman, may I ask you a different question, which is, about your surgical technique. Anyone who has seen you doing surgery can attest that the way how you do the surgery is absolutely fantastic, and you give the best chance for the patients, for complete functionality, recovery, etc. So there are a few questions from the audience related to that. One is from Moises Adel. My apologies if I don't pronounce correctly the name. What your take is about, the mapping of testicular tissue to have some better size. And then other question related, what is the type and caliber of the suture that you are using to do the TESA procedure, and any insight, how to have, performing the best way that TESA procedure?
Well, okay, first place, the testicular mapping, I think, is bogus. It really doesn't predict anything or tell you anything. It was popularized by Turek in San Francisco, and I really don't know any urologists that really believe it has any validity. It's just a bunch of needles being stuck in you for no reason, and it's not predictive. As to the technique, I think this microsurgical technique I advocate is really simple. Anybody can do it. We started out closing the tunica albuginea with just 9-0 nylon, thinking that will cause least constriction of testicular volume. And we did it with interrupted suturing. And then we went down eventually to 6-0 vicryl, but continuing to have interrupted suturing. I think you can go as low as just ordinary 4-0 vicryl, and this is good news for urologists who aren't necessarily microsurgeons. But the crucial thing is to do interrupted rather than continuous suturing. If you do continuous suturing, then that non-elastic tunica albuginea is going to constrict its volume and you'll have pressure atrophy. So just do interrupted suturing. And the other really important thing, and the advantage of using a microscope, is with a microbipolar forceps, you can stop all the little bleeders. And there are going to be little bleeders even on the surface. And you really don't want them to be causing an intratesticular hematoma. I recommend the microsurgical approach. And probably if you want to really be delicate about it, most people who are not really microsurgeons wouldn't have difficulty with 6-0 vicryl interrupted. And I think they can get away with that and not have to use the 9-0 nylon, because we've tried them. We've gradually gone to larger and larger suture to see what would happen very gradually. And I don't see any negative effect as long as it's interrupted suturing and as long as you stopped all the bleeders. The way you stop the bleeders is you have your assistant do continuous pulsatile irrigation with heparinized saline. And with the microbipolar forceps, you can just stop these little bleeders without hurting any of the testicular tissue. That may take 10 or 15 minutes. But the procedure is very brief. You put in the local anesthetic, you expose the testes, and you make this long incision, and you just skim off the outer millimeter, give it to the lab, and they should do a lot of washing, multiple washings of it, so they don't have a lot of blood cells to worry about before they actually start dissecting it. And so I like to hand them bloodless tissue, but if you hand them bloody tissue, it's okay because the lab should be able to take care of that. And then you're going to spend 10, 15, 20 minutes just stopping all those stupid bleeders on the outside, because you stop one and then another one starts. That's the way these little tiny bleeders work. But eventually they'll all be stopped, and then you just close it with interrupted sutures. So the whole operation under local anesthesia really shouldn't take more than a half an hour.
Thank you so much.
And Ellen, have you got another question?
Yes, I have another question for Sherman. It's about the Klinefelter patients. Do you think that age is important to predict the sperm recovery?
I couldn't understand that. It's my hearing. Say it again.
There's a question on the Klinefelter patients. Do you think that age is important to predict sperm?
Well, yeah, now I understand you now. We have always thought age is important because we thought that much like Turner's, there would be a decline over time. But now I don't think that's really true anymore. If there's going to be a mosaic XY island somewhere in that testes, it's really not going to be affected by age. And so we like to do it early, because if we can get the patients fairly early and then freeze their sperm so that they can feel comfortable about the future. But when we haven't done, really old patients, but as old as age 38, we've been able to get good sperm. So I think it's not like Turner's. With Turner's, of course, you want to get them as early as you can because you're going to have, if there are any follicles, they're going to be declining with age, but that won't be true with the seminiferous tubules.
Okay, and I've got a question for Aude, if I may. You mentioned that you slow freezing. How have things changed in the way that we freeze these testicular tissue in the past years? I mean, is there anything special that we can do? And what is your protocol really, in a few words?
Yeah, so I think my promoter, Ellen Goossens, can explain more about it, but shortly, as I discussed in my presentation, what we use is the fragments are transferred in cryoprotective medium containing dimezo and sucrose. And after that, they are transferred to a first freezing protocol until they reach -80. And after that, they go to nitrogen gas. But about the studies on it, I think my promoter, Ellen Goossens, can say a little bit more.
Yeah, well, about this, we have studied different cryopreservatives like glycerol, ethylene glycol, and DMSO. And DMSO was shown to be the best preservation medium for sperm, for testicular tissue. And DMSO is also the medium that almost all centers use to freeze testicular tissue. The addition of sucrose even improves the survival of the spermatogonia after cryopreservation. We have tried slow freezing and vitrification, but vitrification doesn't turn out to work well with testicular tissue. The slow freezing is the method that is used by most of the centers.
Thank you. I have a quick question to Aude. That's from the audience. Harlene Kaur, my apologies if I don't pronounce it correctly. First of all, saying that it was a great presentation, and also asking the question that how long or how many days it takes to get a mature spermatozoa to be formed if you do an in vitro culture. I don't know if you have experience on that or what the literature says about that.
Yeah, I have no experience in it, but I know that for human it's not possible yet. Using human tissue, it was not possible yet. It was possible use in mice, for example, and if I'm correct, it takes fewer time than in the real than in situ. So I think I'm correct, Ellen, if I say that.
Yeah, that's it. But the question is how
many days
exact are these spermatozoa if they are formed in such a short period of time. And in human in vitro spermatogenesis, some people could go up to round spermatids, and that takes 40 to 60 days. So it's a really long culture period.
And are people using like matrices? Are they using like 3D?
That's in organoids.
Yeah, yeah. And that's being done with primates at the moment, or?
These studies I've just talked about wasn't in human. It was by a Belgian team, not my team, but another Belgian team by Christine Wijns. And she was able to culture spermatogonial stem cells and differentiate them up to haploid cells.
A quick question to Sherman. Do you see any benefit of doing testicular sperm extraction the day before of egg retrieval so that you have more time, to recover sperm or get the sperm out somehow? Is it something that can be advantageous or can it be disadvantageous? Any thoughts on that?
Well, we don't do that. We do it the same day. But the advantage that people report, you can see it, is that if you do the TESA the day before, then you're going to see more motility in that testicular sperm. There's going to be automatically some greater development of motility. And I don't think it's because the sperm are really maturing anymore. It's just like what you see in the head of the epididymis in an obstructed state. When the sperm get out of the testicle and they're stuck after a certain period of time, they gain motility automatically. Now, they don't gain fertility in that process. We've shown that, that regular IVF isn't going to work very well, even with highly motile sperm from the head of the epididymis, but the sperm look great. The only advantage then of we haven't done it because I think with testicular sperm, it really doesn't matter. You pick up a normal looking sperm with a flexible tail and the results are good. You don't need to have a motile sperm. But for some people, there might be an advantage in that if there are very few sperm, it's going to be easier to see them and to find them if there's a little motility. So yeah, we haven't done it. We don't find it necessary, but I can see why it'd be an advantage for a team that's less experienced to perhaps be able to see those sperm if there are very, very few of them more easily.
Right. And a little bit different question, that what are your thoughts about posthumous sperm recovery? Is that something that can result in successful outcomes after IVF?
What kind of sperm recovery? I didn't hear you.
Posthumous.
Posthumous. Okay.
The person deceased and then you try to recover sperm. I don't know if you have ever done that.
I have.
But what you think that how many days it can happen, or how many hours it can happen and still recover a functional sperm?
Well, we know that sperm, in the absence of seminal vesicle fluid, or after ejaculation in the female, we know that and that's sort of been process of removing the seminal vesicle fluid via the cervical mucus, it's good for 2 to 3 days. I mean, it's quite fertile for 2 to 3 days. That's why I always recommend to couples, they don't try to time their intercourse, because the egg's only good for maybe 8 hours after ovulation, and you just always want sperm there. So the husbands love it. I just tell them to have a lot of sex and don't worry about when they ovulate, because you always want sperm present. So I think the sperm would be good for 2 or 3 days, and that would be sperm that have not gotten contact yet with the seminal vesicle fluid. I'm sure for testicular sperm it would have to be similar. So I think you have quite a bit of time.
Thank you.
Ellen, is there a final question that you'd like to ask anyone?
Well, I can ask a question, another one for Aude. You mentioned the indications for testicular tissue banking in young boys. You said that cancer patients can benefit from this banking, but also patients with a non-malignant disease. Can you elaborate a bit on that?
Yeah, so patients who have, for example, sickle cell disease, they will also need very high-risk gonadotoxic treatments as conditioning therapy for their bone marrow transplantation or hematopoietic stem cell transplantation. So because of these very high-risk treatments, they also can benefit from testicular tissue banking. Yeah, that's why.
Thank you. Thank you all for that. There have been so many questions, but I think we have to slowly wrap up this session. I'd like to thank everyone for taking time to participate in this session and this discussion. There have been so many questions and it's been so well followed here. I'd particularly like to thank the I3 speakers, Dr. Silber, Aude Braye, and of course, Professor Ellen Goossens. Thank you again, the organizing committee of this initiative, Jacques Cohen, Peter Nage, who's here, Thomas Elliott, Shyster Sandruden, and Marianne Chevetes. And of course, today's Q&A team, who is Alison Bartolucci, Marianne Chevetes, and Anna McLaughlin.
And I also would like to thank for all the speakers, great presentations, great lectures. It was a pleasure to do the moderation with my colleague, friend Giles Palmer. And before I say bye-bye, I also just wanted to draw your attention that next week, of course, we continue with another webinar, and that's going to be on SARS-CoV-2 in assisted reproduction, which is, of course, remaining a very important topic in our everyday life and also in our work. The moderators will be Dr. Ilian Turkaspa and Dr. Filippo Zambelli, with the panelist of Dr. Alan Parker, and speakers will be Dr. Ilan Turkuspa, and he will talk about the COVID-19 may affect male fertility, but it is not sexually transmitted disease. And then Dr. Manuel Viotti will talk about SARS-CoV-2 in the pre-implantation embryo, and Dr. Jason Swain about SARS-CoV-2 in the clinic. So it will be very exciting at the same time, like this webinar, and we all hope to see you there again. Thank you very much. Have a fantastic afternoon, evening. Take care. Bye-bye.
Bye.
Bye-bye. Thank you.
Bye-bye.
Bye-bye.